everyone, it's Rona again, PGY2 with Internal Medicine at Walter Reed, and today I wanted to make another shelf review video focusing specifically on some common EKGs that you might see on your exams. So starting off, let's just start by interpreting an EKG together. So how would we start approaching this one? Just remembering to go through it systematically. We know that this is regular, so it looks like the QRS complexes are occurring at regular intervals. And we also notice that the QRS complexes are narrow, and we notice that the rate is fast. So this is going to be a regular narrow complex tachycardia. Something else we notice when we're looking at this EKG is that you're not seeing regular P waves before the QRS complexes, which makes you think that this isn't going to be some sinus tachycardia. So if you look here in lead 1, we're really not seeing any good P waves that are coming before these QRS complexes. So sinus tachycardia, you would expect to see P waves in that lead. So it seems like this is maybe not sinus tachycardia. But we see here in V1, it's a little harder to see, but you can see that there are these positive bumps that you can note after the QRS complexes. You can see one here, you can see one here, and that's something that's actually called a retrograde P wave. You also see these bumps in some of the other leads like AVR, and overall these form what are called pseudo R waves that are secondary to retrograde P waves. So this is a supraventricular tachycardia. You see a regular narrow complex tachycardia, and those retrograde P waves are really going to be your buzzword for AV-NRT or AV node reentrant tachycardia, and this is going to be one of the most common SVTs or supraventricular tachycardias that you see on your exam. So AV-NRT, this is a regular narrow complex tachycardia, so it's supraventricular. You're not going to see regular P waves as you would expect, but you can see these retrograde P waves as we just talked about on that EKG. And on your test, there is a population that it will most commonly affect. So this is going to be your younger patients, especially those who have a structurally normal heart who are coming in with palpitations. And would you expect the onset for AV-NRT to be gradual or sudden? So you would expect it to be sudden onset, so this is different from sinus tachycardia. If you're running and having an appropriate response, you would expect your heart rate to gradually increase, while for AV-NRT, it'll be someone who's sitting there and then suddenly has rapid onset palpitations. And this is really what's happening with AV-NRT. The main thing to know on your test is that you have two separate conduction pathways with the AV node, and you're going to have regular R to R intervals with P waves that are buried within the QRS complexes. And what is the next best step for someone who is in AV-NRT? So this is kind of a trick question. It'll depend on whether or not they're stable. If they're unstable on the test, what would be your next best step? So this is going to be a synchronized cardioversion, especially if they're having things like lower blood pressure, altered mental status, chest pain. Think about jumping to a cardioversion right away. If they're stable, there's a first-line treatment that the tests love to assess you on. So these are going to be your vagal maneuvers, which help to temporarily slow conduction. And if the vagal maneuvers don't work, there's a first-line medication. So this is going to be your adenosine. So now let's go to a different EKG and interpret this one together. So let's look at this one again. So this one looks a little bit different. We're noticing that this time we do see P waves regularly before the QRS complexes. So we see one here, we see one here, we see one here. But we're also noticing that the interval between the P wave and the R wave are very short, and you notice that the QRS complex looks wider. And then if you look carefully, you will also notice that at the beginning of the QRS complexes, there are sometimes these notches that you can see on your EKG. So the combination of the wide QRS complex, the short PR intervals, and this notching at the QRS, at the beginning of the QRS, which is also called a delta wave, this is going to be consistent with Wolff-Parkinson-White syndrome. So those three things are important for that triad, and this will be, let's say, a 21-year-old who's coming in with palpitations. So the Wolff-Parkinson-White, again, the triad is going to be a short PR interval, a wide QRS complex, and a delta wave, or that notch or slur at the beginning of the QRS complex. And how would you treat a patient who has Wolff-Parkinson-White and is also found to be an AFib? So they do like to test you on this because this is different from AFib for patients who have normal rhythm at baseline. For patients with Wolff-Parkinson-White, the medications that you would use to slow down the heart, like verapamil or beta blockers, can actually cause the patient to go into ventricular tachycardia or ventricular fibrillation. So the first-line medication for a patient who has Wolff-Parkinson-White and AFib is going to be procainamide, and if they're unstable, you're going to want to think about that cardioversion. So let's go into a different EKG this time. So let's say for this case, you have a 36-year-old who's coming in with chest pain. What are you thinking for this one? Now, right away, I think something that everyone would be concerned about is that it looks like there are some ST elevations on this EKG. And you can see them in a couple of leads here. You can see them in lead 1, they're a little bit more subtle. And 2, you can see some ST elevations. In AVF, you can see some ST elevations. And then kind of all along V3 to V6, you're seeing some of these ST elevations. But for a myocardial infarction, you would expect it to be some anatomic distribution, which you're not really seeing on this EKG. And you're also not noticing any reciprocal ST depressions in an anatomic distribution. So it looks like this is more of a case of diffuse ST elevations. And let's say this patient said that his chest pain was more positional, maybe they had a recent viral infection. What would you think is the diagnosis for him? So this is jumping more towards pericarditis. So pericarditis, those diffuse ST elevations are really going to be the key word there. There are some buzzwords that I wanted to emphasize. What might you notice on auscultation? So this is going to be your pericardial friction rub. How would they describe the chest pain? We kind of mentioned this, but positional. It's not going to improve with Restor nitroglycerin like ACS would. They'll say, especially if it's worse when they're supine or laying down and helps to sit up and lean forward, think more about pericarditis, and it'll be more sharp in nature. And you should be looking for something on your transthoracic echocardiogram. So making sure they don't have a pericardial effusion or fluid around the heart. And what is the first line treatment for most causes of pericarditis, especially if you think this is something viral or idiopathic? So the majority of the time, the correct answer is going to be picking high-dose aspirin and colchicine. There is one situation where this is not going to be the correct answer for you on your test. And this is if you have a patient with peri-infarctious pericarditis. So these are especially those patients who have higher risk because they had delayed reperfusion after a STEMI, especially if it was greater than 3 hours from symptom onset. And in this case, you generally primarily support them with medications for pain. And you want to avoid NSAIDs in this setting because of complications like free wall rupture. And when would you be worried about constrictive pericarditis? So a little bit of a different, just reviewing the terminology. Acute pericarditis is when you have acute inflammation of the layer surrounding the heart, while constrictive pericarditis is when that layer becomes so thickened and fibrosed that it actually limits the filling of the heart. So you might hear some things on auscultation, and that buzzword is a pericardial knock. There are some other buzzwords that really help you increase your suspicion for pericarditis on your exams. Prominent X and Y descent, so especially if they did something like a right heart catheterization and told you that the waveforms on that seem to show prominent X and Y descents. If you notice that they have elevated, they have jugular venous distension or Kussmaul sign, and the way they might describe it on your exam is that every time the patient is breathing in, there's no decrease in the jugular venous pressure. So if the jugular venous pressure is staying the same or increasing when the patient takes a breath in, that's consistent with Kussmaul sign. And you could see something on imaging that raises your concern for constrictive pericarditis, and that's going to be calcifications. And this is an example of a very notable case of someone who had severe calcifications of their pericardium surrounding the heart, which was seen on imaging and was causing constrictive pericarditis. And now let's go to another EKG here. So switching topics, and how would you interpret this one? So for this one, we're noticing that you do have P waves before the QRS complexes, but we're not seeing regular P waves before some of them. Like this one, you're not seeing a P wave before this QRS complex here. And then if you go down here, you're noticing that there are also some P waves where you have a P wave and then there's no QRS complex following it. So it really doesn't seem like there's a clear association between the QRS complexes and the P waves. And this is a type of heart block. Take a moment to think about what that would be. So this is going to be your third degree or complete heart block where there's no clear association between the QRS complexes and the P waves. And it's pretty high yield to be able to differentiate the different types of heart block on your exam, because the higher grade heart blocks, especially if it's like a second degree Mobitz type 2 or a type 3, you would think about putting in a pacemaker. So let's just review the terminology. What is the definition of a first degree AV block? So this is if you have a prolongation of your PR interval. So if it's more than 200 milliseconds or more than 5 small squares, you can see this in healthy patients and athletes. So it's not necessarily concerning on its own. What if it's a second degree type 1 AV block? So this is going to be when your PR interval is progressively lengthening, and then you have a drop in your QRS complex. Now this is different from a second degree type 2 AV block, which is when you have a random drop of your QRS, so there's no progressive lengthening of your PR interval. And then for complete heart block, like we just saw, there's no association between the P waves and QRS complexes. And I think this is a really great visual. So we see for a healthy patient with a normal EKG of these P waves and QRS complexes following. For Mobitz type 1, you're seeing these prolongations of the PR interval. So this interval to this interval to this interval gets longer, and then you have a P wave and there's no QRS complex following that. And then for Mobitz type 2, you're noticing that there's no prolongation of the PR interval. You have a very consistent interval, and then there's a random drop of the QRS complex. So let's say just some high yield scenarios on your boards or your shelf exam. So first degree AV block with diffuse bilateral wheezing and hypotension in a patient who has a lot of home medications, maybe someone who has a history of heart failure. So this is concerning for beta blocker overdose. The keywords here are the heart block, the diffuse wheezing, and the hypotension. What is the treatment for beta blocker overdose? So this is going to be IV atropine to help with that heart rate, fluids, and IV glucagon is a unique medication to treat for beta blocker overdose. And a different scenario, let's say you have a younger female who comes in with complete heart block, and maybe they got a biopsy of some different organ, maybe something like the lungs, which was showing non-casating granulomas. So this is going to be sarcoidosis. And then let's say you have an IV drug user with a new murmur who also has heart block. So this is concerning for complication of infective endocarditis, something like a perivalvular abscess. And now let's just practice what we discussed with our topics with a couple of EKGs here at the end. So let's say you have a patient coming in and this is what you see on their EKG. Now, I know what you're thinking. You're like, wait a second, I thought we were just talking about heart block. Shouldn't the rhythm be slow? It looks like these QRS complexes are pretty normal in rate. And I think this is one of the reasons why it's so helpful to keep things systematic when you're reading EKGs. So when you first look at the rate, it looks irregular, and you might think maybe this is AFib, but then you notice that there are definitely some regular P waves that you see here, here, here. So it doesn't seem like AFib, because for AFib, you would not expect to see P waves. And then you notice that there are episodes where the rhythm is regular, and then suddenly it becomes irregular because there is a dropped QRS complex. So this is actually a case of a patient who had random drops in the QRS complexes without any progressive PR prolongation. So this is a second degree Mobitz type 2 AV block pattern. And now what would you see for this EKG? So this is reviewing a previous topic. Let's say it was a patient who came in with palpitations. Right away, we say that the QRS complex is narrow. This is a regular rhythm, but a fast rate. So it's a regular, narrow, complex tachycardia. And you're not seeing any clear P waves for the QRS complex. But then if you look really carefully, you can see here, let me highlight this for things like V6, you notice that there are these subtle bumps which are actually showing evidence of retrograde P waves. So the QRS complex is narrow, and overall this is actually a patient who's coming in with AV NRT, which is a type of supraventricular tachycardia. And just reminding again, if this patient is stable, you would consider things like vagal maneuvers and adenosine. If this patient was unstable, you would think about synchronized cardioversion. And finally, let's look at this last EKG here together. So we notice a couple things right away. It looks like the QRS complexes are wider. You're noticing a P before every QRS this time. But then you also notice that the PR interval seems to be short. And it looks like, just to highlight one of them here, you have these notches at the beginning of your QRS complexes. So you have these slurs here at the beginning. You see one here. You can see one here as well. So this is an evidence of that triad again with the wide QRS complexes, the short PR intervals, and that delta wave. So this is a patient going back to the Wolff-Parkinson-White triad. And then the very last slide, I just wanted to highlight this because it was very confusing for me when I saw it as answer choices. So AV-NRT and AV-RT are both narrow complex regular tachycardias, and they're only different by one letter on your exam, so I wanted to highlight how they're different. AV-NRT you're going to see much more commonly as an answer choice that's correct. It's going to have a short PR interval with those retrograde P waves, frequently in healthy young patients who don't have any structural heart abnormalities. AVRT is associated with an accessory pathway and pre-excitation. So this is commonly going to be seen in association with Wolff-Parkinson-White. You would expect to see P waves on this one, but both of them are narrow complex regular tachycardias. I hope this was helpful. Please continue to share your feedback with me, and if you have any additional questions or feedback, I would love to hear it.